Hello, good evening everyone. We'll just wait for the verification of the audio and video and then we'll start. So we'll wait for the audio. If someone is there, can reply. Okay, so now we'll start. So thanks for the confirmation. Okay, so good evening everyone. Myself Dr. Rijul Agarwal. So I have chosen this topic cleft orthodontics, keeping in mind the upcoming INI exam also, and the past NEET exam in the March. They have asked a number of questions, and cleft is a very hot and favorite topic of the people there. So that's why I have deliberately taken up this topic. So in the 1 hour session, the time allotted to me, I'll be trying to cover as much as possible, not the complete cleft part, so that you get a basic gist of this topic and is able to answer all of the questions for your exam. Okay, so once again, good evening everyone. So we'll start. So cleft orthodontics. Okay, so beginning with this first topic, that is the epidemiology or of the cleft. A number of questions in the past exams have been asked on this, so I'll be taking up starting up with the basic part of it. So cleft lip and palate is the most common congenital defect involving the face and the jaws, and it's the second most common of all the congenital anomalies occurring in the whole body. The most common or the first most common being the club foot. So the incidence of cleft lip and palate combined worldwide is 0.3 to 4.9 per thousand of the population. Just remember, ye facts and figures have been asked in the exam, so that's why I mentioned this is according to the latest data. And cleft palate alone is 0.1 to 1.87 per thousand live birth. Whereas in India, this data from India, it's combined is 1.25 per thousand live birth, and cleft palate alone is 0.46 per thousand live birth. Out of this, unilateral is most common than bilateral. There is a preponderance towards the left side as compared to the right side. It's more common in males with the left side predilection, and in females, cleft palate alone is greater. In the last NEET exam only, they have asked this in the form of which of the statement is correct. So in INI, as we all know, there is a pattern of multiple options being correct, multiple answers being correct. So all of this data is very important for the upcoming exam. Proceeding further, so about 70% of the cases of cleft lip and palate and 50% of cleft palate alone are non-syndromic in nature, whereas the ones which are syndromic appear as a part of a multiple congenital anomalies, which can be grouped further into these are monogenic syndromes, chromosomal aberrations, or being part of an association or a complex of multiple congenital anomalies of unknown etiology, and teratogenic syndromes. Teratogenic syndromes, as we all know, are the symptoms or the syndromes which occur due to the administration or intake of teratogens during the gestation period. So there are more than 350 syndromes known to have associated with the cleft lip and palate. Students are again emphasizing these facts and figures are very important for the exam. So just don't forget any of the figure or number which is mentioned here. So coming up to the proceeding forward, so it's the incidence is highest in the Afghan or Mongolite population, that is 4.9 per thousand live birth, and least in the Negroes, that is 4.4 per thousand live birth. So the reason which is said or highlighted that why is there a decrease incidence in or there is a racial predilection for the decreased incidence in them is that there is a habit or a killing babies within any congenital defect born there, because in their culture it is considered as an evil sign. Secondly, due to the lack of proper resources, so children born with bilateral clefts generally do not have any source of nutrition except the breastfeeding, and breastfeeding becomes sometimes impossible due to the severity of cleft. And as we all know, the Negroid population has inability to access the basic fundamental resources to access this knowledge. So that's why there is a prejudice, or what when can say that the reason responsible for this lower incidence of cleft lip and palate in their population. This figure is again important of the highest 4.9 and in which population. Okay, so this was the first part of this topic, the epidemiological data of cleft lip and palate. Okay, coming up with the classification, students please know there are right now more than n number and of classification systems of cleft lip and palate, and till now with passing each and every day further new classification systems come up. The aim of classification is to simplify the data and to develop a universal system for studying or abbreviating this cleft lip and palate. So as we all know, we cannot study, so I have picked up a few important which is important from a exam point of view and which are historically important as well. So starting with the first, this was the simplest and the first earliest system of classification that was given by Victor View in the year 1931, in which he divided or classified cleft lip and palate into 4 groups, that is group 1, 2 and 3 and 4. The group 1 involved the cleft of the soft palate. Group 2 involved hard and soft palate up to the incisive foramen. Group 3 is completely unilateral, and group 4 is the severe most, that is complete bilateral, involving the palate, lips and the alveolus. Next is the Carnahan stripped pie classification system, in which he divided into boxes, that is from 1 to 9 in the year 1971. So it was further modified by Elsahi, Millard and Friedman. So this is the Carnahan wide strip classification. Again, image important from the image based question, in which they can give you this image and ask you, this image related to which classification, or this image highlights which. They will please note, they are not going to ask you classify the cleft, or they will ask you the numbering or something like that. Okay, so just remember this diagram and its association with the classification system of cleft lip and palate. Okay, next is the Lashal classification system given by Ockrins in their 1987, the most simplest classification system, in which it was abbreviated. The each of the term Lashal, that is LAHSHAL, is a short form or abbreviation of the type or the part of the mouth involved in the cleft lip and palate. L being the lip, A alveolus, H is the hard palate, H is the soft palate. The left and right side are it also helps in the indication or classifying of the laterality of the cleft defect. And if you want to indicate whether it's a bilateral or unilateral, okay, so if we want to record whether the cleft is complete or incomplete, it is a complete clefts are abbreviated in capital letters, and incomplete clefts are indicated by small letters. So this classification system also helps in the indicating the laterality and completeness of the cleft. Laterality means whether it's on left or right side, and completeness and incompleteness by whether it's by capital and small letters. Okay. So another important point is whether that it was modified in the year 2005, and the second letter H, the capital H, was excluded. So it was done in order to exclude the possibility of classifying bilateral clefts of the hard palate. Okay, how, why cannot a bilateral cleft or hard palate cannot occur? I'll tell you when we'll discuss the embryological aspect in the upcoming slides. Okay. Coming to the next classification system, that is the Indian classification or the Nagpur classification system. This is the most popularly used in all our colleges and the most commonly asked in your exam. It is a Nagpur classification system, that is group classified into group 1, 2, 3 and 3. Okay, 1 is the foremost, that is the cleft of lip. 1A is the cleft of lip with the cleft of alveolus. Group 2 is cleft of palate alone. 2S is the submucous cleft of the palate, and group 3 is the cleft of lip and palate. And the right and left side are indicated by R and abbreviated by the letters R and L, and both R and L for bilateral clefts. I hope it's clear until now. So this was the most important classification systems of the cleft lip and palate. Next, coming up to this table. Okay, so this table is very important for the exam point of view. So what does this table indicate? First is the stage, next is the time post fertilization and the related syndrome. So this table indicates as the date or the time at which this stage is occurring, and agar us time pe this stage is affected will lead to this syndrome, subsequent syndrome. So at day 17 there is germ layer formation and initial organization of syndrome structures. So the related syndrome would be the fetal alcohol syndrome. 18 to 23 there is neural tube formation, as we all know from the embryological classes. So it will lead to anencephaly. So for our class, today's class, the important time is this. That is the formation of organ system, the primary and the secondary palate. Primary palate is from day 28 to 38 and secondary palate is day 42 to 55. Okay, if the primary palate is affected, please note ये जो है डेज में दे रखा है, ये वीक्स में भी बहुत इंपॉर्टेंट है. एग्जाम में दे कैन आस्क यू, दे जनरली आस्क यू इन द फॉर्म ऑफ वीक्स ओनली. द ऑप्शंस आर गिवन इन द फॉर्म ऑफ वीक्स ओनली, सो जस्ट रिमेंबर दैट. एंड सो 28 to 38 डेज अगर प्राइमरी पैलेट की फॉर्मेशन पे इफेक्ट होगा, इट विल लीड टू क्लेफ्ट लिप एंड पैलेट. एंड अगर प्राइमरी पैलेट बन चुका है एंड द फॉर्मेशन in the effect is in the days of 42 to 55, it will lead to effect in the formation of cleft palate alone. So this part is important for our today's class. Rest you all should know for exam point of view as well, be it pathology, oral pathology. Okay, so what is primary and secondary palate? So for our classification or simplification, I have just my first slide may I am mentioning it. Primary palate is the palate clefts anterior to the incisive foramen are grouped as the clefts of the primary palate, and those posterior to the incisive foramen are known as the clefts of the secondary foramen. So this incisive foramen acts as a dividing structure for our classifying or our simplifying of the cleft lip and topic of the cleft lip and palate. Okay, So coming to the basic embryological background, so simplify our understanding of cleft lip and palate. So first of all, the nasal pit, as we all know, this is a diagram. The nasal pit or the nasal pit comes from above. The maxillary process from the first pharyngeal arch comes from the lateral sides and fuses with the frontonasal process. The maxillary process joins the lateral and the medial nasal process to form the future upper lip and maxilla. And how the medial and lateral nasal processes are formed? These are formed by the nasal pits, which divides the frontonasal into medial being the central one. This is the mesial nasal process, and this is the lateral nasal process as labeled in the diagram as well. So the nasal placodes divide the frontonasal into medial and lateral nasal process. The lateral nasal first fuses with the maxillary process, and then these two in turn fuses with the medial nasal process. So अगर cleft lip and palate होना है, अगर इनमें से किसी भी diffusion में defect, if there is any defective fusion in any of this process, it will lead to the formation of cleft lip and palate. So next is this figure, that is the mid phase develops between 4 to 8 weeks of the intrauterine life. Okay, so this is the embryological. Next is this point. अभी इससे पहले मैंने मेंशन किया कि that the mid phase embryologically develops between the 4 to 8 weeks of intrauterine. So अगर हमें prenatal या before birth diagnose करना है, so mid phase hypoplasia, the earliest which can be picked up on ultrasonogram is at 14 weeks of intrauterine life, not before that, but the formation is initiated at the time from 4 to 8 weeks. Please remember this. अगर क्वेश्चन फॉर्मेशन पे आ रहा है, so it develops between 4 to 8 weeks of intrauterine life, whereas on an ultrasonogram mid phase hypoplasia can be picked up after 14 weeks only. So this is the what is diagnosed, that is there is an absence of a nasofrontal angle, depressed nasal bridge, and hypoplastic malar eminence on a 3-dimensional USG indicates that there is a small maxilla in the fetus. This is the angle which is the maxilla nasion mandible angle, the MNM angle, and its average value is 13.5 degrees. Okay, till now we are only able to pick, that is at 14 weeks, that there is mid phase hypoplasia. We cannot say that is mid phase hypoplasia is because of clefts. So for clefts it can be diagnosed earliest at 16 weeks, and that too by a level 2 ultrasonogram. प्लीज़ ये तीनों फिगर्स ध्यान रखना है. 14 वीक्स पे मिड फेज हाइपोप्लेजिया, 16 वीक्स पे ओरोफेशियल क्लेफ्ट, एंड दैट टू बाय लेवल 2 USG, एंड दिस आल्सो सर्व्स एज अ गोल्ड स्टैंडर्ड फॉर डायग्नोसिंग द प्रीनेटली cleft lip and palate. Okay, so this is the earliest at the time where you can diagnose this. Okay, I hope it's clear, the developmental age and the time where you can diagnose. So coming to the cleft lip and palate. So cleft lip and palate, as we all know, cleft lip occurs as the first, we'll start with the cleft of lip and primary palate. So this occurs as a result of failure, as I have already told you in the embryological aspect, between the medial and the maxillary prominence between 5th week of development. अगर रेंज में पूछे, so it is between 5 to 8 weeks. ठीक है. Next is the midline cleft of the upper lip. Midline cleft is very rare and which can occur due to a split in the medial nasal process, but it's extremely rare. Okay, so cleft lip and palate 5 to 8 weeks में हो सकता है due to defective fusion. Okay, and as we know, fusion जो होता है वो होता है medial and lateral nasal process with the maxillary process, और maxillary process में होते हैं क्या है, initial developing tooth buds of the primary, central and lateral incisor. तो fusion defective होगा will not only involve the lip and the alveolus, but it will lead to the defective formation of these teeth as well. So the most commonly effective teeth by cleft of lip and palate are the central and lateral incisor. Okay. Next is, so as we all know, as I've already told you, cleft lip is most commonly associated with the cleft of alveolus as well. Okay, not always but most commonly associated. And अगर है तो it will lead to the effect of development of central and lateral incisor. If the cleft extends deep into the primary palate, it will result in the cleft of alveolus. And lastly, this term, that is the Simoniid bands. These are occasionally the clefts of lip and alveolus have a bands of soft tissues bridging across the two sides called Simoniid band. So these are the result of the incomplete or defective fusion between the two sides, embryological defective fusion, and the term which is given to them are the Simoniid band. Again, another important MCQ. Okay. Next is the cleft of the secondary palate. So cleft of the secondary palate occurs due to the lack of fusion of the left and the right palatine shells. So as we all know from our embryological classes, that the palatine shells are initially perpendicular, and they get, with the descent of the tongue, they get upright and starts to fuse from anterior to the posterior side. So they are formed vertically downwards on the 45th day on the side of the tongue. तो जब टंग डिसेंड करती है, they become from vertical they become horizontal and starts to fuse. So they starts fusion from 8th week and proceeds backward and are continues till the 12th or 17th week of intrauterine life. So अगर कुछ प्रॉब्लम होगी या क्लेफ्ट पैलेट अलोन है, सो अगर फ्यूजन डिफेक्टिव इस स्टेज पे हुआ है इसलिए. Okay, this is the cause for cleft of the secondary palate. So this is the diagrammatic representation. अगर हम axially देखें उठा from the downwards, so this is how the fusion is occurring. That is, fusion occurs from after the shells become horizontal and starts fusing from anterior to posterior, and we all know from the Pierre-Robin syndrome as well. That's why it's most common. अगर tongue descend downwards नहीं हुई, so ये fusion नहीं होगा. Okay. So this was the prenatal diagnosis. Prenatally diagnose कर सकते हैं. We cannot do any kind of treatment till now. Till now we have just diagnosed and classified cleft lip and palate and got to know its causes. Okay, so coming to the treatment aspect of cleft lip and palate, so it's divided into various stages. That is during infancy, during the late primary and early mixed dentation stage, late mixed dentation and early permanent dentation, late permanent dentation and late teens after completion of the facial growth. So coming to the first stage, अगर first stage पे बच्चा हमारे पास आए, so what can we do? So at this stage हमारे जो एम्स है वो क्या क्या है? पेशेंट को फीडिंग करना है, पेशेंट का स्पीच डेवलपमेंट है, बस. देर इज़ नो नीड टू करेक्ट एनी काइंड ऑफ माल अक्लूजन एट दिस स्टेज कि क्राउडिंग है क्या है. देर इज़ नो नीड. सो आवर एम राइट नाउ इज़ टू assist the patient in feeding and assist in speech development, nothing else. So feeding, what we do is fabrication of feeding plate or passive maxillary obturator, and for speech development we require the repair of the lip and palate. Lip and palate की सर्जरी चाहिए. तो सर्जरी के प्रिपेयर करने से पहले हमें पेशेंट की सर्जरी करने से पहले we need to do some pre-surgical infant orthopedics, that is PSIO, and after PSIO we do the surgery of cleft lip and palate at this stage. Okay, so हम each and every point देखेंगे, starting with the feeding plate or the passive maxillary obturator. So this helps to restore the palatal cleft and aid in sucking. helps in preventing the maxillary arch from further collapsing. And ये कैसे बनती है? It's are formed of using cold or heat cure acrylics. So next is this image shows how the mother is instructed to feed the child. The child को generally हम supine position पे it is said that he should be fed. Okay, the child should not be lying down, otherwise what will happen, the milk will directly go into his nasopharynx due to the opening in the palate. And plus there should be frequent burping. Okay, this is how the child is instructed, or sorry, the mother is instructed to feed the child. Okay, so feeding ho gaya, and now getting prepared for the surgery, that is the pre-surgical infant orthopedics. So it was popularized by Burstone. So what does it do? It uses the removable appliances to reposition the maxillary segment in infancy before the initial flap closure is done. Next is this age. So it is done as 3 to 6 weeks before the lip closure. Please note, PSIO is always done before any surgery. After surgery there is no infant orthopedics which can be done. So what is PSI? What is done? So what happens is, in unilateral cleft, what happens, there is defective fusion, so there is displacement facially towards the cleft adjacent to the cleft side. And in bilateral clefts, what happened, the premaxilla is protruding forward. So what is the aim of pre-surgical infant orthopedics? Is to reposition these segments back to their original position so that the surgery could be done easily. Okay, and makes the patient look better at an early age. So what are the two movements which should be carried out using this orthopedics? There is expansion of the collax segment, okay, and pressure against the premaxilla to reposition it posteriorly to correct its position. So how it's done? It's done by placing light elastic straps across the anterior segment, then which applies a contraction forces. So here light elastic straps, and what is the names of these straps? These are steri strips and Tegger down. Okay, the patient's caregivers, the child's caregivers are instructed on how to place these elastic straps across this segments. So what does it do? It applies a contraction force on this segment. Okay, so this helps in closure of this cleft segment. They apply elastic force and helps in closure. Okay, the caregivers are instructed to change these strips daily. Okay, so as to apply a contraction force. So होगा क्या इसका result? जब surgery होगी, there will be less tension in the tissue and it will lead to a better aesthetic result at the stage of surgery. Okay, next comes the PNAM, that is pre-surgical nasoalveolar molding. It was popularized by Grayson. Please note, PSIO के under ही PNAM, these are the devices which come under PSIO. These are, first is the active molding, and then next are the passive growth appliances. This is a classification table. हम हमारे एग्जाम पॉइंट ऑफ व्यू से जस्ट नेम्स इंपॉर्टेंट है, एंड जो हमें इंपॉर्टेंट डिस्कस करना है, दिस इज द PNAM appliance, pre-surgical nasoalveolar molding duct, and this is the image of this appliance. इसके नाम में ही है nasoalveolar molding, that is this part, there is a nasal stent and this is the alveolar part. It molds or helps in the development of the nasal part and the alveolar part prior to the surgery. So what is this appliance? This is a palatal plate that is constructed on infant's maxillary crest from an accurate impression. In addition, there is an acrylic bulb attached to the maxillary plate with the rigid wire. So what does it do? It lifts the nasal dome and molds the shape of the nostril and soft tissue of the cleft region. Okay, the construction of the nasal stent is delayed until the clefts of the alveolus is reduced to 5 to 6 mm. So it's attached at 45-degree angle in the cleft lip region. Please note there is a small opening which is provided in the plate to maintain the patency of the airway in case the plate अगर patient swallow कर जाए. Okay. So this is the PNAM appliance. So next important point is the principle on which it's based. So what is the principle? So it is said that there is high levels of hyaluronic acid in the newborns which link the cartilage. So because of this high levels of hyaluronic acid, it's easier to mold the infant's tissue at this age because of the inherent elasticity of the cartilage at this age. So by simple orthopedic or feeding plates, we can mold them into a desired shape at this age prior to any surgery, so that the result or aesthetics of the surgery which occur are much better as compared to the patients with or without these appliances. Okay, so important इसमें है who gave this PNAM thing, that was given by Grayson, the image of this appliance, okay, and the principle based on which it is based. Okay, so इन्फेंसी में हमने फीडिंग प्लेट दे दी, PSIO कर लिया. Now the patient is prepared for the surgery. So the next question which comes is at what age the surgery is done. So lip closure का पहली बात है aim क्या है, why it's done at this age. So as I've already told you, aim is to assist the patient or help the patient in the normal speech development. So what are the guidelines? So these guidelines were advocated by Millard, that is the rule of 10, that is 10 weeks of age, 10 pounds of weight, and hemoglobin should be 10 gram %. Okay, aim is to provide good aesthetics of the lip, prolabium and the columella with a functional lip which can provide a good lip seal. So what's important, as I've already told you, it's important for articulation, phonation and optimal balance of the muscular forces. So what are two techniques which are involved? These are the Tennyson triangular flap procedure and the Millard's rotation flap. Okay, next is the surgical palate repair. The palate repair is done at the age of 12 to 24 months. Aim is to provide a well-functioning uvula that helps in providing the good seal, velopharyngeal seal. What is velopharyngeal seal? We'll discuss it further when we do velopharyngeal insufficiency. Okay, and helps in developing proper swallowing and phonation. And an intact functioning palate free of any fistula is the aim of the surgery. Both helps in phonation as well as eating food. Okay, next important is the features of a operated cleft. So what are the features? So skeletally, the lip surgery has a minimal effect on facial growth, reduce the width of the cleft by soft tissue molding. Whereas अगर hard palate surgery करते हैं, there is maxillary retrusion due to scar tissue, and soft palate surgery has a minimal effect on the overall facial development. So अगर maxillary retrusion होगा तो क्या होगा? There is increased incidence of crossbite, crowding, and सबसे common जो malocclusion मिलती है, that is the maxillary hypoplasia or class 3. Why? Because हमने सर्जिकली सूचर से पैलेट को क्लोज कर दिया. इट्स नॉट एबल टू ग्रो ट्रांसवर्सली. एट इन्फेंट एज पे हमने इसको क्लोज कर दिया, लीडिंग टू मैक्सिलरी हाइपोप्लेजिया. सो नेक्स्ट इंपॉर्टेंट क्वेश्चन इज द मोस्ट कॉमन टाइप ऑफ malocclusion or skeletal malocclusion which is found in an operated case of cleft cleft palate is class 3. Please note it's only after hard palate. Lip or soft palate surgery has a minimal effect on facial growth. So अगर क्वेश्चन में अगर दे want to twist it, वो lip surgery या soft palate दे सकते हैं, and they can ask. So the option would be none of the above because it has minimal effect on the facial growth. So this was the primary stage from 0 to 24 months. So now coming to the stage 2, that is primary dentation from 24 months to 6 years. So at this stage, no active orthodontic therapy treatment is taken. द ऑब्चरेटर जो पेशेंट को दिया है उसको जस्ट ट्रिम करके करना है, सो एज टू अकोमोडेट द इरप्टिंग प्राइमरी टीथ. अगर क्रॉस बाइट है, प्लीज़ नोट कौन सी क्रॉस बाइट स्टेज पे करेक्ट करेंगी, तो क्रॉस बाइट लीडिंग टू फंक्शनल शिफ्ट. फंक्शनल, अगर कोई क्रॉस बाइट उस पेशेंट के फंक्शनल मैंडिबुलर शिफ्ट कर रही है विच कैन लीड टू डेवलपमेंट ऑफ skeletal asymmetry, only those cross bites are corrected at this stage, be it anterior or posterior. Because cross bites problem से अगर skeletal asymmetry हो रही है then only it is corrected at this age, otherwise there is no need to for any orthodontic intervention. Why? Because अगर cross bite problem हमने in general भी we start correcting it, there is no guarantee that it won't reappear when the permanent teeth erupt. And next is the oral hygiene instructions. And lastly, the major reason for crossbite is due to the surgical site scar formation and contraction. So please note, only those crossbites at the primary dentition stage which can lead to functional shift. Why functional shift? Because it can lead to the formation of skeletal asymmetry in the patient. Coming to stage 3, that is the late mixed dentition to early mixed permanent dentition, that is 6 to 11 years. So at this stage, arch expansion can be taken so as to provide space for the eruption of the permanent teeth. Maxillary protraction devices like the use of face mask, okay, is taken up. Fixed orthodontic treatment can be initiated, but it's done on the basis of the eruption stage or the presence of the permanent teeth. And the most important is the placement of alveolar bone graft to facilitate the eruption of permanent canines. Okay, so what is the alveolar bone grafting? That is ABG, that is alveolar bone grafting. So in the cleft or the cleft alveolar site where there is defective formation of bone, a graft of bone is taken from the ribs. I won't be discussing the sites, it is already been discussed in the surgery classes. Okay, the important principle for orthodontics I'm just going to tell you here, that from a graft is taken from the ribs and it's taken and it's placed in the defective site at this stage. This is known as ABG, that is alveolar bone grafting. And when it's done at this stage, that is the stage early permanent or mixed dentition, this is known as secondary alveolar bone grafting, that is SABG. And its only aim is to facilitate the eruption of permanent canine or lateral incisor or any teeth which is not, we take up a X-ray and we see if the teeth is not able to erupt because of the absence of bone, only then SABG is taken, secondary alveolar bone grafting is done. So the question is, the main reason for secondary alveolar or alveolar bone grafting done at 7 to 10 years is to encourage the eruption of canines or lateral. No other reason is there for doing any kind of secondary alveolar bone grafting. Okay, so the next question which comes up or which have come up in the past exam are the what are primary SABG, secondary SABG or tertiary. So primary SABG is done during lip repair, that is infancy. This is no longer done nowadays because it is said that any primary grafting done during the primary dentition stage will lead to the non-development or reduced development of the maxilla, which we don't want. So this is not done now. The only grafting which is recommended is the secondary grafting, that is the during the late dentition stage to facilitate the eruption of teeth. अगर क्वेश्चन में आ रहा है कि देयर ऑन एक्सरे देर इज एब्सेंस ऑफ टूथ बड with respect to canine, so there is no reason for doing any alveolar bone grafting. It is only done to facilitate the eruption of canines and lateral. अगर वहाँ tooth bud ही नहीं है, there is no point in doing this surgery or subjecting the patient to any kind of surgery. Okay, lastly the tertiary bone grafting. This is the least common, still done in some centers, but it's least common. It's done during permanent dentition after orthodontic treatment. And why it's done? It's done to close up any opened up fistula. Okay, expansion के बाद अगर कोई fistula या defect open up होता है in the palate, only that is the reason why this tertiary bone grafting is done. It's still done, but it's the least common of all. The most common or which is done is the secondary alveolar bone grafting only, and primary grafting is not done at all anywhere. Okay. So moving up to the stage 4, that is the fixed mechanotherapy at the age of in the late teen, that is 12 to 18 years. So why it's done? That is to assist in final correction, alignment along with aesthetics should be achieved. Okay, settling of occlusion, and if the planning is done for orthognathic surgery, then it's done for that fixed mechanotherapy. Okay. So coming to the orthognathic surgery of patients with cleft lip and palate. So what is the reason? That is, there is a continued mandibular growth after completion of active orthodontic treatment, leading to the development of anterior and lateral crossbite. Okay. So what happens is there is deficient maxillary growth from the scarring of the primary surgery of the cleft palate, leading to retrusion of the maxilla. So surgery is done to restrict or retard to set for mandibular setback, or most commonly it's for the maxillary advancement. Okay, it's done. And after this, all the surgeries are done for a prosthetic replacement of any missing teeth can be carried out. Surgical protocol, how Leaford surgery BCSO, this is the same as done for any normal orthodontic patient and as for a cleft patient. So I'm not discussing Leaford and Leaford surgeries and BSSO in this class. Next, in the upcoming class, we can take up cleft orthognathic surgery where we discuss BSSO and how it's done. Okay. So I'm just mentioning what is the reason for carrying out any orthognathic surgery. Next is this Oslo protocol. So what is Oslo protocol? So students, please note, as I've already told you इससे पहले कि what is there's pre-surgical orthopedics all across the world, depending on their population and the healthcare infrastructure they have. Studies have been done, and based on that, the respective countries and institutes of their country have developed some protocols to carry it. As I've already shown you, there are multiple number of surgeries to be carried out during the growing or the development age of a child. So depending on the healthcare infrastructure and the population which is affected on the epidemiological data, each and every country prepare up its own protocol. So how to proceed with when a patient of a cleft lip and palate is born, how to proceed with its management. So this Oslo protocol was the earliest one protocol. Each country, most of them have up their own protocol. India in general have not come up with their own protocol. They are in process. Whenever it comes up, we'll take up with that. Okay. So what is the Oslo protocol? So it was the earliest protocol which was established in 1948. So what were the key elements of it? There is no pre-surgical orthopedics to be carried out according to their protocol. Next is combined surgery of cleft lip in infancy, along with the closure of the nasal floor in the region of alveolus and hard palate, and the same operation. So what they do is cleft of lip and hard palate surgery are done at the single stage operation, and soft palate surgery is delayed, and it's done in the early childhood. And after these two surgeries, any secondary operation is delayed until the patient reaches the age of 18 to 20 years. Okay. And lastly, all surgical operations should be done as conservatively as possible with no unnecessary harm to hard or soft palate. So the important thing is this, that there is no pre-surgical orthopedics recommended by the Oslo protocol. And next is the combination of the surgery of lip and hard palate and soft palate surgery is delayed. So this is a diagrammatic representation of the technique. Okay. So this is a simplified table of the timings of the repair of the stage reconstruction of lip and palate deformities. Important from your exam point of view. So cleft lip repair after 10 weeks, that is at 3 months of age. Cleft palate repair 9 to 18 months, that average being 12 months. अगर soft और hard palate का separately पूछे तो soft palate at 12 months, hard palate at 5 to 6 years. pharyngeal flap or pharyngoplasty. Okay, 3 to 5 years or later based on speech development. Maxillar or alveolar reconstruction with broad grafting 6 to 9 years, as I've already told you, based on the dental development. Orthodontic surgery in late teens. Rhinoplasty, or that is lip revision, after age of 5 years, but it is preferred at skeletal maturity combined with orthodontic surgery. And cleft revision is after initial remodeling and skull maturation is complete. Best performed at the age of 5 years. So this table is very important. That is the timing of it. Coming up with the communication deficits in individuals with cleft lip and palate. So there is language deficit, as we all know, due to the incomplete or for defective formation in the lip and palate. Hearing loss. Why hearing loss? Due to, most important, just remember this name, tensor villi palatini. And as we all know, this tensor villi palatini attaches to the eustachian tube, and eustachian tube is important for maintaining the pressure difference. So अगर वो नहीं होगा, it will lead to defect in middle ear and loss of communication between the nose and the middle ear. In addition, अगर eustachian tube properly form नहीं होगी, it will lead to infections of middle ear as well. That is why there is hearing loss in cleft lip and palate patient. There can be hearing loss because of this defect in this muscle formation. Just remember its name, tensor villi palatini. Altered speech production, speech sound errors, laryngeal pathologies and phonatory disorders. There is impaired resonance and velopharyngeal inadequacy. What is velopharyngeal inadequacy? We'll discuss in detail because this is very important. What is velum and what is it? So students, just look at this diagram. I'll zoom it in a bit. So what is velum? Velum is another name of soft palate. So during nasal, this is the nasal cavity, this is the oral cavity. So what happens? So when we are breathing, this soft palate is down and the oral cavity is closed. So the air is able to go inside the nasopharynx. Whereas when we are speaking or eating, this soft palate comes up and forms a barrier between the soft nasal cavity or the nasopharynx and the oropharynx. So what happens is the air is able to go out through this oral cavity, which helps in speech production. अगर ये soft palate या velum में कोई भी तरह का defect हो जाए, either in formation or anatomical defect, it will lead to velopharyngeal dysfunction, also known as velopharyngeal inadequacy. Okay, velopharyngeal dysfunction or velopharyngeal inadequacy, that's why it is abbreviated as VPI. Okay, so what is velopharyngeal dysfunction or inadequacy? Condition where velopharyngeal valve doesn't close constantly. It can be due to any reason. क्या reason है उस पे आएंगे during production of oral sound. अगर ये valve close नहीं हो रहा during the production of oral sounds, then it's known as velopharyngeal dysfunction or velopharyngeal inadequacy. So होता क्या है ये एक, अगर हम इसको ऊपर से देखें, this is a round structure, this pharynx is a round structure. आगे से आता है soft palate या velum, साइड से आता है that is the lateral pharyngeal valve, और posteriorly आता है posterior pharyngeal valve. Okay, posterior pharyngeal valve. अगर किसी भी इस स्ट्रक्चर में डिफेक्ट होगा, यहाँ पर एडिक्वेट सील नहीं होगा, लीडिंग टू इनकंसिस्टेंट प्रोडक्शन ऑफ द ओरल साउंड. हमारे क्लेफ्ट लिप एंड पैलेट से रिलेटेड है, दैट इज़ द डिफेक्ट इन द फॉर्मेशन ऑफ सॉफ्ट पैलेट। तो उसमें वेलोफैरिंजियल डिस्फंक्शन और इनएडिक्वेसी में आते हैं। फर्स्ट ऑफ ऑल, फर्स्ट इज वेलोफैरिंजियल इनसफिशिएंसी। Velopharyngeal insufficiency. What is velopharyngeal insufficiency? Anatomic और स्ट्रक्चरल डिफेक्ट। अगर इनैटमिक या स्ट्रक्चरल डिफेक्ट है इस वॉल्व में, दैट प्रिवेंट्स द inadequate or adequate closure of the velopharynx. It is known as velopharyngeal insufficiency. Anatomy और structural defect किस वजह से हो सकता है? Due to, most commonly it's due to cleft lip and palate, जो हमारे आज के लेक्चर के लिए इम्पोर्टेंट है। सो क्या ट्रीटमेंट होगा इसका? ट्रीटमेंट वुड बी सर्जरी या फिर प्रोस्थेटिक डिवाइसेस जो इस डिफेक्ट को क्लोज करे। जैसे आता है स्पीच बल्ब ऑब्चुरेटर, पैलेटल ऑब्चुरेटर, जो हमने प्रोस्थो की क्लासेस में देखे, पैलेटल लिफ्ट प्रोस्थेसिस जो लिफ्ट कर देगा सॉफ्ट पैलेट को, ऑब्चुरेटर जो इस डिफेक्ट को क्लोज कर देगा बेस्ड ऑन द डायग्नोसिस की व्हाट इज़ द प्रॉब्लम, दैट्स एनाटमिक डिफेक्ट में क्या है। सो ओनली इन वेलोफैरिंजियल इनसफिशिएंसी, प्लीज नोट, we can go for any kind of surgery or prosthetic device. So what are the other two? That is next is the velopharyngeal incompetence. Velopharyngeal incompetence क्या है? It's a neurological disorder. Neurological disorder means velum या soft palate बना नॉर्मल है, बट ड्यू टू न्यूरोलॉजिकल डिसऑर्डर उसका ओपनिंग और क्लोजिंग या अप और डाउन मूवमेंट हैम्पर्ड है, लीडिंग टू इट्स पुअर मूवमेंट। एंड मोस्ट कॉमन कॉजेज क्या हो सकते हैं इसके? सेरिब्रल पाल्सी, एनी काइंड ऑफ न्यूरोमस्कुलर डिसऑर्डर, हेड ट्रॉमा कैन लीड टू वेलोफैरिंजियल इनकॉम्पिटेंस। तो इसका ट्रीटमेंट कभी भी सर्जरी तो नहीं हो सकता, हमें अंडरलाइंग न्यूरोलॉजिकल डिसऑर्डर को ट्रीट करना है, ना ही कोई प्रोस्थेटिक डिवाइस इसका ट्रीटमेंट हो सकता है। ओके, सो अगर एग्जाम में वेलोफैरिंजियल इनकॉम्पिटेंस पूछा है एंड दे हैव गिवन यू ऑप्शंस लाइक पैलेटल ऑब्चुरेटर, पैलेटल लिफ्ट, सो प्लीज नोट नन ऑफ द अबव इज द करेक्ट ट्रीटमेंट ऑप्शन फॉर वेलोफैरिंजियल इनकॉम्पिटेंस। ओके, आई होप इट्स क्लियर between velopharyngeal insufficiency and velopharyngeal incompetence. And lastly जो आता है third type, that is the velopharyngeal mislearning. Velopharyngeal mislearning, इसमें क्या प्रॉब्लम है? There is absence of any structural or physiological defect. So what is the problem? There is individual mislearning effects. Individual during their developmental stage, okay, किसी में होता है their speech is not adequately developed, okay, so that is known as velopharyngeal insufficiency mislearning, and इसका treatment would be speech therapy only, no surgery, no medicine, no obturators, anything in that. The treatment is speech therapy in this case. Okay, I hope these three are clear: velopharyngeal insufficiency, velopharyngeal incompetence, and velopharyngeal mislearning. These all three come under the broad category of velopharyngeal dysfunction or inadequacy. Okay, so students, this was all I can cover up in the allotted time. There is still few more topics, important topics from this cleft lip and palate, which we'll take up in our complete sessions during our class. I hope this session was informative for your upcoming exam. Okay, if there is any doubt, you know where to reach me. You can ask me anytime. Just keep studying. Okay, and all the best. Thank you. So I'm going to end this session.